this is a good opportunity to show another case, and I would love to get your take on this. Here we go. So I would call this my super challenging case. And this is a recent one. Child PUA, no significant cirrhosis, biopsy-proven HCC. He's got multifocal tumors. He's got a pretty good distribution of tumor throughout his liver, all right? At your institution, how would you tackle this case? I'll tell you what we did, and it was not exactly the way that you would have thought it would have gone. And so how would you have tackled this?
So in our place, the first discussion comes whether they get liver-directed therapy or a clinical trial or systemic therapy. In all likelihood, being at an academic institution, there's a strong likelihood this patient would get a clinical trial. But let's say clinical trial is not available and they're getting liver-directed therapy for the sake of discussion. We would probably start with the radioembolization, and by meaning start with the radioembolization, you do the mapping, and then you make the decision after the mapping, right? So I don't make a decision as to how I'm going to treat until we do a mapping angiogram and see which out of these that we can select and isolate, similar to what Kirema was referring to 5 minutes ago about trying to isolate tumors, even if you have to do it sequentially, because that's been our approach as well, instead of just doing a shotgun whole liver approach here, which I don't think is probably the best idea.
Sid, what about systemic for this patient? Is that something you would consider at your institution?
So let's say they weren't on a clinical trial and we decide to do liver-directed therapy. I think there's two scenarios. You either do liver-directed therapy and then you combine it with systemic right away, or you do the liver-directed therapy and then you assess for the response, and then you might decide to do systemic therapy later if you want to. We've kind of taken that approach, a much more conservative approach, knowing the fact that systemic therapy, while has made major breakthroughs in the last 4 years, still has a lot of baggage. There's still a significant rate of significant adverse events. It is very expensive. It is very involved for patients in that they have to get infusions at an infusion center every few weeks. So if they don't need it, why should you offer it to them, right? So now our approach has been, you do the liver-directed therapy, you do a scan in 2-3 months. If there's viable disease, then you can consider systemic therapy.
Based on this images I'm seeing here, I mean, liver-directed therapy, there's going to be a ton of vessels feeding all of these tumors here. 100%. So, I mean, basically every single branch of the hepatic artery. And so it kind of comes back to my question, like, if you can just get the bigger tumor there, what is your response to liver-directed therapy with all the other lesions?
Why can't we get the smaller tumors?
Just all of them?
Yeah.
Sequentially.
Well, then we can do
not all at one sitting. Yeah, sequentially.
I think you highlighted an important thing. And
we don't have... Oh, go ahead. Good.
I was going to say, Juan Jimenez, I watch him talk on this all the time, and he says it perfectly. He's like, and you said this too just now, Sid, the mapping is part of my diagnostic workup.
Uh-huh.
Like, I'm not making a treatment decision until I do a mapping.
Correct.
But I will tell you, so this patient went on a clinical trial, and the AFP went from 8.4 to 11.2, but relatively stable disease, but no significant treatment response. And the patient's well-informed, has an incredible oncologist, and the oncologist was like, hey, we're not making many strides. And when we first talked about this patient, they asked us to biopsy this because there was no evidence of cirrhosis. So we biopsied it. We knew it was HCC, and our thought was, let's give Y90 a shot to start. Child PUA clinical trial made a lot of sense. Went on a clinical trial, no significant response, didn't want to sit here and let things just grow. So let's do something a little more definitive.
Did you target? So I'm looking at this, of course, mapping. So because I really don't do whole liver at the same time. So the other question is, what do I target first? Do I go for the right? I don't know what's feeding that segment for, but are we going to start with the side with dominant disease usually? So did you guys do this sequentially, or how did you?
Well, so here we go. Okay, so I'm interested in your opinions here. Zach, you haven't talked yet, so I want to get you. All right, so this is what so a guy has a replaced right. So there we go, replaced right, multifocal feeders, right? A big tumor in the right, basically tumor in every branch of the left. I could play this again here. This was what the left looked like. Pause it there. And this is what the right looked like.
Yeah, so when I think about these types of cases, because we are in a somewhat data-free zone, right? You know, if we wanted to look at quote-unquote phase 3 data, I think it would be either LEAP 12 or Emerald 1. I don't think this would be a great combination, TACE plus immunotherapy. But I think, what's going to eventually cause issue is disease progression and hepatic decompensation with this amount, right?
Yes.
So I think, at least at our institution, there would likely be some form of systemic backbone, right? And for me as an interventionalist, having systemic therapy on board gives me time, right? Because I'm not worried about if I treat this big one coming off the right, the left side is just going to explode, hopefully, right? And so we would probably do some combination of systemic therapy plus local regional therapy. And so my goal here is to prevent worsening disease burden inside the liver, decompensation, and then, death. You have great targeting of all of these tumors, but particularly the replaced right, that huge tumor, you're going to get a really effective, dose to the tumor. And so I'd probably target that one first with some sort of systemic backbone to give me time so I don't have to start like stacking local regional therapies one after another quickly to prevent the other ones from progressing, and then taking our time and slowly going after the rest of them.
You talked about, yeah.
There's something I love that I'm seeing here, when I'm thinking, and is how much of your contrast is going into tumor, right? So that when you're treating at least, and I agree, I would approach it really similar to SAC. I would start with that right side, but I know that when I pick a dose, I know it's mostly going to go to tumor, just based on this.
Okay.
So I love that.
So you talked
and
about
also,
this.
And also, sorry, one more thing. Sorry, when you're thinking about biology, right? This is a patient that has already been on systemic. AFP's 8, and he hasn't really been progressing. So somewhere you're in a tumor biology, at least at this stage, that hasn't. This tumor, which is what we fear, right, when we are doing local regional, is are they going to progress quickly? But that test of time, right, so that it has proven that it's really not that aggressive at this stage. So I do think we have some time.
Well, you also talked about this, and I do want to highlight that. You said, you could get selective and do multiple rad segs if you could. So you can see those segment 4 branches. Those are isolated feeders to what were large tumors on the cross-sectional imaging. So my intent was we're going to go multi-compartment to segments 2 and 3. We're going to go multi-compartment to that replaced right, because obviously the tumor's taking up the majority of the dose. So, you give a dose there, and then we were going to rad seg the 2 tumors in segment 4. So that's how we did it. And I think there's many different ways to tackle it. We broke it up into 2 different treatment days, and this is how it looked. So rad seg 500 gray to that larger tumor up in segment 4, the smaller one, another rad seg, and then we multi-compartment to safety. We did 70 gray to normal on segments 2 and 3, but it wound up giving us tumor doses around 300 to 200. Remember, they were very hypervascular tumors. Brought him back a month later and did a multi-compartment lobar dose to the right hepatic, which got us 262 to tumor. And so and we did 130 gray. It was just a 130 gray to the perfused, 262 to tumor. So about a T to N of 2 to 1.